Thanks for joining me today and welcome for our survivorship special topic for this month. We've been doing special topics each month here at Cancer Services, and all of our previous videos are available for viewing on our website, which is cancerservicesonline.org/special topic. You can find it on our YouTube channel, which is youtube.com/at Cancer Services. And then also you can find it on the Triad Cancer Connection podcast if you just want the audio. So hopefully you'll keep up to date with all the various topics that we've offered. And today we have a very interesting discussion that I think is probably less commonly known about for many people. We're going to be discussing the effects of high blood pressure on cancer survivorship. And we are lucky to have an expert in our area, Dr. Ken Bodek, who is a cardio-oncologist with Novant Health Cardiology. He shared some about heart health and cancer survivors in our June special topic interview, so you'll want to go back and check that out. And today we're going to focus especially on high blood pressure in cancer survivors. And this is an important topic because the general population, 50% of the average person in America does have high blood pressure or hypertension, but it is higher rates among cancer survivors, and the effects can be more challenging. And so we're so grateful that Dr. Bodek is here to share about what you need to know about high blood pressure and cancer survivorship. So I am going to turn it over to Dr. Bodek. Thank you so much for being here and for sharing all of your expertise with us today.
Oh, certainly. Let me just get my screen up there. All right. So now I don't believe that what I'm going to present here is over the top for the lay audience, but I have intentionally kept it challenging. There'll be a lot of information. The details, however, are less important than trying to understand the big picture. So I'll begin. Cardiovascular disease has emerged as the leading cause of non-relapse related mortality in cancer survivors. In this talk, my next slide here. In this talk, I'll present data demonstrating that hypertension is not only more common in cancer survivors, but it is also more deadly. I'll present several studies that demonstrate clearly that cardiovascular risk factors contribute to excess mortality in cancer survivors. And this data is consistent across the spectrum of various cancer groups. There's ample evidence that hypertension is a major risk factor for the development of chemotherapy-induced cardiotoxicity. The emergence of so-called targeted cancer therapies with tyrosine kinase inhibitors has further increased the need to closely monitor blood pressure more than we are accustomed to doing in actively treated cancer patients. My goal today is to convey the vital importance of assessing traditional cardiovascular risk factors in cancer survivors and to persuade you of the need to aggressively manage them. So let's begin with a quick overview of hypertension and its effects in the general population, and then we'll move on to specific considerations regarding cancer survivors. Hypertension is prevalent in the general population. The 2017 ACC/AHA guidelines define hypertension as systolic blood pressure 130 millimeters of mercury or higher, or diastolic blood pressure 180 millimeters of mercury or higher, based on at least 2 blood pressure readings obtained on at least 2 occasions. This definition is stricter than the previous guidelines, which defined hypertension as blood pressure 140 over 90 millimeters of mercury and above. As a result of the stricter definition, the prevalence of hypertension has increased from 1/3 to almost half of the US adult population. As the population becomes more obese and meals have shifted from traditional home cooking to greater consumption of high sodium processed foods, rates of hypertension have increased. Such conveniences and a sedentary lifestyle unfortunately come at significant health cost. As you can see by the slope in these next figures, of these lines representing mortality due to ischemic heart disease versus systolic blood pressure in the left panel and stroke versus systolic blood pressure in the right panel, the risk of death from heart disease and stroke is higher as a person's usual blood pressure rises and diminishes as blood pressure improves. This is true in all age groups evaluated. In fact, a 10 millimeter mercury reduction in systolic blood pressure leads to a 40% lower risk of stroke death and a 30% lower risk of death due to ischemic heart disease. Cancer survivors are at particular risk for cardiovascular disease. There's a higher burden of cardiovascular risk factors, including hypertension, in cancer survivors as compared to the general population. The risks imposed by hypertension extend to an increasingly large population, even as newer cancer therapeutics have reduced cancer mortality. About 69% of cancer survivors are currently alive 5 or more years after their diagnosis. About 18% of present-day cancer survivors were diagnosed at least 2 decades earlier. Some of the increased prevalence of hypertension in cancer survivors relates to overlapping risk factors, such as smoking and obesity, that are common to both cancer and hypertension. Additionally, cancers exert a combination of direct and indirect adverse effects on blood pressure. Indirect effects relate to the type of cancer therapy that's employed. Unfortunately, many cancer therapies can promote the development of hypertension. In fact, treatment with chemotherapy is regarded as an independent risk factor for developing hypertension. The right side of this central illustration shows hazard ratios for cardiovascular disease. A hazard ratio of 1.00 would indicate no excess risk. However, the hazard ratio here is 1.37, so cancer survivors as a group have almost a 40% greater risk of cardiovascular disease than the general population, even after adjusting for traditional cardiovascular risk factors. The table shown provides a listing of cancer treatments associated with hypertension. The ways in which each of these results in hypertension, highlighted here in yellow, extend beyond the scope of this talk, but you can see that a variety of complex pathways interact to raise blood pressure. In addition, factors such as anxiety and cancer-related pain can exacerbate blood pressure elevation. While some types of cancer are more likely to lead to hypertension than others, some therapies employed for the treatment of cancer also have a greater association with hypertension than others. Anti-VEGF tyrosine kinase inhibitors target a receptor, also known as vascular endothelial growth factor, that resides on certain types of cancer cells. Targeted therapies for cancer have been very effective at improving cancer-related outcomes. In fact, they're now frequently part of treatment plans for a variety of cancers. However, they're also notorious for causing hypertension. In a large meta-analysis of 71 studies comprising more than 29,000 patients, treatment with TKIs increased the risk of developing hypertension nearly 4-fold. The reported incidence of hypertension with VEGF inhibitors is substantial and varies widely, as highlighted here in the table. However, because of the way this data was collected, the true incidence is even higher. First, the oncology literature relies heavily upon the CTCAE classification of adverse effects. Using this common terminology criteria for adverse effects, severity of adverse effects is graded on a scale of 1 to 5, with 1 being mild and 5 being death. For the purposes of such grading, hypertension is defined as overall blood pressure greater than 150/90, or a diastolic blood pressure increase from baseline of more than 20 millimeters of mercury. So this excludes milder occurrences of hypertension from the reporting. Additionally, studies of cancer therapies typically report only adverse event severity grades of 3 or above. For hypertension, this would consist of patients in whom blood pressure elevation caused symptoms. In other words, patients who had chest pain, heart failure, headache, and other neurologic symptoms, or patients who suddenly required more intensive blood pressure lowering therapy, either an increase in individual medication dosage or resorting to a multi-drug regimen. Given these reporting guidelines, this table undoubtedly underestimates and provides a lowball estimation for hypertensive effects. If comparison is made between on-treatment blood pressure with pre-treatment blood pressure and an increase in diastolic blood pressure of at least 20 millimeters of mercury is included, even if the patient's blood pressure is still in the normal range, then elevation of blood pressure with TKIs is a universal effect. This figure shows that changes in blood pressure along time intervals following treatment with TKIs. The greatest increase in blood pressure relative to baseline occurred during the first 4 weeks of treatment. After that, the magnitude of further increases gradually diminished, but as you can see that all these points are above that green baseline, the blood pressure elevation persisted through 52 weeks of therapy. Large clinical trials have supported intensive blood pressure reduction in individuals at high risk for cardiovascular disease. These studies did not include cancer patients. Nevertheless, evidence has gradually emerged that cancer survivors should be included in this high-risk group, and they also should have aggressive intervention to mitigate their inherent risk. So next, let's review what the medical literature tells us regarding both the prevalence of cardiovascular risk factors and the consequences of cardiovascular risk factors on various cancer survivor populations. Hypertension is potentially one of the so-called multiple hits that contribute to increased cardiovascular mortality in cancer survivors. In fact, it has a huge effect when present. For example, in one population of cancer survivors, hypertension significantly increased the risk of coronary artery disease by 6-fold and the risk of heart failure by a factor of 19. Breast cancer survivors are at greater risk for cardiovascular disease mortality when compared with women without breast cancer. This study in 2016 analyzed data from the population-based Long Island Breast Cancer Study Project and sought to determine the extent to which breast cancer survivors experience cardiovascular disease-related outcomes relative to women without breast cancer and the time when any excess risk of cardiovascular disease first becomes manifest. Women with breast cancer were age-matched with women without breast cancer. The figures show that overall mortality was increasingly greater in breast cancer survivors as compared to women without breast cancer. You can see how those lines are diverging in the left panel. In the right panel, we see that, at least early on, there was no difference in cardiovascular disease mortality. The lines were superimposed on one another. However, by year 7, cardiovascular disease mortality was progressively higher in breast cancer survivors than for women without breast cancer, and this seemed to drive excess mortality. After year 7, breast cancer survivors had nearly twice the risk of cardiovascular disease mortality compared to those who did not have a diagnosis of breast cancer, even though the average number of pre-existing cardiovascular risk factors in both groups was about the same. So there seems to be something particularly onerous about cardiovascular risk factors in these cancer survivors. Survivors of adolescent and young adult cancer also are increased risk for developing cardiovascular disease. A retrospective study by Chow in the Journal of Clinical Oncology evaluated long-term cardiovascular disease outcomes occurring up to 12 years after cancer diagnosis in about 6,000 survivors of adolescent and young adult cancer who were members of the Kaiser Permanente Southern California Health Plan. The development of cardiovascular risk factors significantly increased the risk for cardiovascular disease among these survivors. Of 3 cardiovascular risk factors examined, this study, like other analyses in the literature, identified hypertension as one of the strongest cardiovascular risk factors for cancer patients. In fact, when all cancer types were combined, the incidence of cardiovascular disease was higher for hypertension than for diabetes and dyslipidemia, with incident rate ratios of 3.67 for hypertension compared to incident rate ratios of 3.18 and 1.79 for diabetes and dyslipidemia, respectively. Overall, adolescent and young adult cancer survivors had greater than 2-fold risk of developing cardiovascular disease, as indicated by an incident rate ratio greater than 2 when compared to patients without history of cancer. The magnitude of relative risk varied across the spectrum of different cancer types, as you see here. However, it's clear that while risk varies, it is elevated in all. As you can see in the highlighted area, the incident risk ratios are all greater than 1. I've shown that these cancer survivors had increased risk for developing one or more cardiovascular risk factors. I've also shown that these cancer survivors had increased risk for cardiovascular disease. Nevertheless, the differences in cardiovascular risk factors only partially explained their increased incidence of cardiovascular disease. It's conceivable that cardiotoxic cancer therapies or some shared pathogenic mechanism between cancer and cardiovascular disease make up the difference. What seems clear is that having any of the cardiovascular risk factors further increases the risk of cardiovascular disease in cancer survivors. Cancer survivors who developed cardiovascular disease had a more than tenfold increase in overall mortality when compared to survivors without cardiovascular disease. The study of adolescent and young adult cancer survivors is not unique in its findings. As seen in this table, cardiovascular disease incident rates are significantly higher in various cancer survivor populations, even after adjusting for cardiovascular risk factors. This is a retrospective study that compared cardiovascular risk in more than 36,000 survivors of adult onset cancer with a non-cancer control population. Cancer survivors compared with controls were significantly more likely to have hypertension. Cancer survivors with 2 or more cardiovascular risk factors had the highest risk of cardiovascular disease compared with non-cancer controls with less than 2 cardiovascular risk factors. However, cancer survivors with cardiovascular risk factors were not only at higher risk for developing cardiovascular disease, but they were also more likely to die. Looking at overall survival curves, 8-year survival was significantly worse in cancer survivors who developed cardiovascular disease as compared to cancer survivors without cardiac disease, 60% versus 81%, and this represents a decrease in survival by about 25%. In this figure, 2 groups of cardiovascular disease are shown in the graph, one with a cancer history and one without a cancer history. 8-year survival was significantly worse if individuals had been treated for cancer. You can see the divergence of the lines. Cancer survivors with cardiovascular disease did worse even when compared to a population of non-cancer patients with similar cardiovascular disease. This points to the importance of strategies to improve cardiovascular health in at-risk cancer survivors long after completion of their cancer therapy. Overall survival of cancer patients who develop cardiovascular disease is poor. Not only were cancer survivors with cardiovascular risk factors at higher risk for developing cardiovascular disease, as seen on previous slides, but they were also more likely to die, as shown in this figure. Let's see whether we can tease out just how much hypertension adds to the risk. Data from the Childhood Cancer Survivor Study shows that with aging, prevalence of cardiovascular risk factors, including hypertension, increases among survivors. As seen on this slide, at age 50, the prevalence of hypertension was 40% in survivors, but only 26% in the sibling group. Relative risk has been determined for different combinations of risk factors. Now, this is a busy table, but I've tried to direct your attention to the relative risk attributable to hypertension. The print there is small on my screen, and I'm sure it's small on yours as well. But I'll tell you that the prevalence of hypertension alone significantly increased the risk for all major cardiac events among survivors. Although hypertension alone had a relative risk of almost 20 for developing heart failure, the development of hypertension in a patient who also happened to have diabetes increased the risk by about 35 times. We can look at the incidence and predictors of congestive heart failure after autologous hematopoietic cell transplantation, also known as stem cell transplantation. Armenian in the journal Blood examined the incidence and predictors of heart failure in around 1,000 patients undergoing autologous stem cell transplantation for hematologic malignancy. A total of 88 patients developed heart failure. The cumulative incidence of heart failure was just under 5% at 5 years and a little under 10% at 15 years following transplantation. Prior to transplant, many patients had received an anthracycline-based chemotherapy regimen. Additional potential cardiotoxic exposures unique to stem cell transplants include conditioning with high-dose chemotherapy and total body irradiation. Not surprisingly, the risk of heart failure increased with the cumulative anthracycline doses seen in this figure. Prior exposure to high cumulative dose of anthracycline therapy is an independent predictor of heart failure. However, the presence of hypertension appears to have had a synergistic effect on the development of hypertension in these patients, as shown here. Using statistical models to assess the effect of individual cardiovascular risk factors on the development of heart failure, the presence of hypertension in recipients of high-dose anthracycline resulted in a 35-fold greater likelihood of developing heart failure. In this study by Armenian, the 5-year survival after heart failure diagnosis was only 40%. Now, the most common cause of death in this study group was still relapse or progression of primary malignancy, representing about 45% of all deaths. However, 18% of all deaths resulted from heart failure. So this and other studies suggest that despite more effective cancer therapies, an excess of cardiovascular deaths in cancer survivors may limit overall survival. Cancer-related cardiotoxicity is a growing concern with newer anti-neoplastic agents, even as their cancer-fighting efficacy has reduced cancer mortality. Among survivors exposed to cardiotoxic therapy, modifiable cardiovascular risk factors are associated with increased risk of major cardiac events. We see here in breast cancer patients treated with trastuzumab, also known as Herceptin. Trastuzumab is used to treat HER2-positive breast cancer. Hypertension was associated with a 60% increased likelihood of developing trastuzumab-related heart failure or a decline in heart contractility as measured by left ventricular ejection fraction. I've circled the odds ratio, and again, similar to what I said about incident rate ratios or hazard ratios, 1.0 is no excess risk. Here you see an odds ratio of 1.606. That indicates 60%, almost 61% increased risk of developing trastuzumab-related heart failure or decline in heart contractility. So what this boils down to is that in addition to the increased cardiac morbidity suffered by these affected patients, the resulting interruption of trastuzumab therapy is associated with poorer breast cancer outcomes. So it's kind of a double whammy for patients. By now, it should be clear to all that cancer survivors are more likely than the general population to develop hypertension, and that hypertension contributes to worse outcomes. So how then should we approach blood pressure management in these patients? General blood pressure goals for cancer survivors have been extrapolated from non-cancer populations, and the blood pressure lowering therapy treatment step protocols for cancer patients are basically the same as those for other patients with hypertension. Nevertheless, there are some caveats when it comes to treating patients during active cancer therapy. Signaling pathway inhibitor hypertension requires special attention. Signaling pathway inhibitors include VEGF inhibitors such as tyrosine kinase inhibitors, which I briefly mentioned earlier, and another group of therapies called proteasome inhibitors. The latter are now standard therapy for treatment of multiple myeloma. The Cardiovascular Toxicities Panel of the National Cancer Institute recommends actively monitoring blood pressure throughout treatment with more frequent assessments during the first cycle of anti-VEGF treatment. I'd earlier indicated that TKIs universally raise blood pressure. This slide shows that proteasome inhibitor carfilzomab results in hypertension in about 18% of those treated. Predictors of a hypertensive response include being overweight, that is, having a body mass index of 25 kilograms per meter square or greater, pre-existing blood pressure elevation, and age greater than 59. The goal for hypertension control in patients receiving VEGF inhibitor therapy is a maximum blood pressure under 140 over 90 millimeters of mercury. Efforts to reach this goal should begin before the initiation of VEGF inhibitor therapy. For patients who have normal baseline blood pressure, a sudden rise in diastolic blood pressure may signal a need to consider early pharmacologic therapy. Antihypertensive treatment should be initiated in any patient having an increase in diastolic blood pressure of 20 millimeters of mercury or more, even if the absolute blood pressure measurement is still in the normal range. Temporary cessation of TKIs, also known as a chemotherapeutic holiday, will sometimes become necessary to help lower blood pressure when hypertension becomes difficult to control. The kinase inhibitor should then be reinstituted at the lower or at least the same dose after appropriate up titration of antihypertensive agents has achieved blood pressure control. For VEGF inhibitors that hang around the body a long time, such as bevacizumab, also known as Avastin, the hypertensive drug effects subside much more slowly, so a pause in therapy may need to be extended out to 4 weeks while blood pressure lowering efforts continue. In National Cancer Institute sponsored trials, bevacizumab was held for systolic blood pressure greater than 160 or diastolic blood pressure greater than 100. Unfortunately, failure to control blood pressure may necessitate permanent discontinuance of the VEGF inhibitor. This is an undesirable outcome from a cancer treatment standpoint, of course. Therefore, before doing so, consider whether other things not already addressed, such as frequent use of non-steroidal anti-inflammatory drugs such as over-the-counter Advil, and inadequate pain control are contributing to refractory hypertension. There's another special concern related to VEGF inhibitor use. Patients for whom active TKI use requires them to take blood pressure lowering medication may become hypotensive, get blood pressure that's too low when the TKI therapy is stopped, unless blood pressure lowering medication is simultaneously reduced. So patients should be forewarned. When treating hypertension in patients undergoing cancer therapy, understand that a fixed dose of antihypertensive medication may not always be possible. The level of blood pressure lowering aggressiveness may need to be tempered at times during active cancer therapies because patients may experience nausea, loss of appetite, mucositis, and other problems that may lead to poor oral intake and dehydration. For those patients who may be at risk for volume depletion due to anorexia or nausea vomiting acutely during cycles of chemotherapy, it may be preferable to employ a so-called sick day protocol, which temporarily withholds certain blood pressure medications on treatment days. Although some studies have demonstrated the efficacy of potassium-sparing diuretics for cancer patients in some settings, diuretics may not be appropriate for everyone. Drug-drug interactions represent another potential hazard for cancer patients. When it comes to blood pressure lowering therapy, generally avoid verapamil and diltiazem due to their significant potential for drug-drug interactions. These antihypertensive agents are an inhibitor of an enzyme, CYP3A4, which affects drug levels of many anti-cancer therapeutics and in turn cause safety and efficacy concerns. This table shows the most common drug-drug interactions with antineoplastic agents. Although great strides have been achieved in extending cancer survival, the cardiovascular toxic effects of cancer therapy and the accelerated underlying cardiovascular disease may produce a sort of glass ceiling that limits overall survival. Can we improve overall survival in cancer patients, not just by focusing on more effective cancer therapies, but by also addressing cardiovascular risk better? The collective body of evidence suggests that we can. All medical providers need to be educated to recognize the unique cardiovascular risk of cancer survivors and work towards mitigating that risk. Patients must be actively engaged in this effort also. Although blood pressure varies with stress levels, level of physical activity, and time of day, trying to maintain a resting blood pressure generally under 130/80 is a good rule of thumb. Home blood pressure monitoring can be a useful tool. Out of hospital or self-measured home blood pressure monitoring has the recommendation of the AHA and the AMA. Regardless of where blood pressure is taken, accurate blood pressure monitoring requires proper technique. Meaningful blood pressure measurements should be obtained while at rest in a relaxed state and with an empty bladder. You should not have consumed caffeine, smoked, or exercised in the last 30 minutes. Sit for 5 minutes before measuring blood pressure. Both feet should be flat on the floor. The blood pressure cuff should be properly sized and positioned at heart level with the arm supported. A cuff that is too small for the circumference of your arm will give an inaccurately high blood pressure reading. When using a wrist blood pressure machine, support your arm across the chest. Take slow, deep breaths in and out as the blood pressure machine inflates and deflates. Consider measuring blood pressure a couple of times a day each week. Measure blood pressure in the morning and in the evening. Blood pressure is not static. It changes with physical activity, and it even varies with the time of day. Blood pressure tends to be highest in the early morning hours. So it really is stressful to get up in the morning and get up out of bed. Recognize also that there is a natural difference in blood pressure between the two arms. Up to 10 millimeters of mercury is not unusual. Therefore, initial blood pressure should be measured in each arm. Use the arm with the higher reading for subsequent measurements. Sodium reduction continues to be a mainstay of dietary modification. The average daily sodium consumption by adults in the US is about 3,500 milligrams, greater than the 2017 ACC-AHA hypertension daily recommendation of less than 1,500 milligrams. Keep in mind that about 75% of dietary sodium consumption comes from processed foods, so replacing them with fresh fruits and vegetables rich in potassium can be helpful. For people who are not on a restricted potassium diet due to kidney problems or taking certain medications that cause greater potassium retention, increased consumption of potassium-rich foods can enhance sodium excretion from the kidney, which reduces blood pressure. For many people with hypertension, losing some weight is helpful. Conversely, packing on additional excess pounds will further raise blood pressure. There are several non-pharmacologic interventions to reduce systolic blood pressure by about 5 millimeters of mercury each. Reduce weight by 5 kilograms or around 11 pounds. Note that systolic blood pressure decreases by about a millimeter of mercury for every 2 pounds of weight lost. Lower sodium intake by 1,000 milligrams or to less than 1,500 milligrams a day. Perform 150 minutes per week of moderate intensity physical activity. Reduce alcohol consumption to not more than 2 drinks a day for men and 1 drink a day for women. Medical compliance, of course, is very important. This should be obvious, but one of the causes of seemingly resistant hypertension, called pseudo-resistant hypertension, is the failure to take blood pressure-lowering medications as prescribed. Many patients with hypertension require a multi-drug regimen. Blood pressure control is achieved with 2 or 3 medications from different drug classes taken together. Once daily dosing regimens are preferable for improving medication adherence. Single pill combinations of 2 or 3 medications reduce pill burden, but generic options for these drug combinations may be limited. Now, patients may wonder whether taking so many medications is really necessary. For patients already treated with a blood pressure lowering medication, the addition of a new medication from a different drug class often results in greater blood pressure lowering than simply escalating the dose of the previously prescribed medication. The ability to use smaller doses of medications in combination can also reduce the risk for side effects. I recommend that my patients with hypertension purchase a home blood pressure machine. I emphasize that it's equally important to sample blood pressure outside of the doctor's office. In conclusion, a complex relationship exists between cancer and hypertension, with increased prevalence of hypertension among cancer survivors, shared genetic predisposition, or at least common risk factors. A direct and indirect effects of cancer and cancer therapies also are important, and a marked increase in the development of cardiovascular disease, leading to statistically higher mortality in cancer survivors. The good news is that hypertension is also manageable. In addition to medication, there are some non-pharmacologic ways to lower blood pressure. To reiterate, if you're overweight, try to lose about 5% of your body weight, or about 10 to 12 pounds. Lower your daily sodium intake by 1,000 milligrams, or less than 1,500 milligrams per day. Read food package labels for sodium content. Avoid prepared foods, cook from scratch if possible, and add less salt. Engage in some sort of physical activity, preferably 150 to 300 minutes of moderate intensity exercise per week, but if that's not possible, then any activity is better than no activity. Reduce alcohol consumption to not more than 2 drinks a day if you're a man, or not more than 1 drink a day if you're a woman. Doing all of the above could potentially improve blood pressure, systolics, by 20 millimeters of mercury without adding any more medication. This is the take-home message for today. Hypertension is the most common cardiovascular risk factor, affecting almost half of the US population. Yet, compared to the population at large, there's something particularly onerous about hypertension in cancer survivors. This should prompt us to be more vigilant in identifying hypertension and more aggressive in controlling it to improve cancer survivor outcomes. Thank you very much for your attention.
Awesome. That was super helpful. Okay, so I just have a couple of questions. Thank you so much for all of this really useful information. So the questions that I have that I think our audience maybe would wonder about is, if they are somebody who has hypertension, maybe they had hypertension before a diagnosis, you know, maybe it came on through diagnosis, treatment, whatever, or after treatment's been over, who is the right person to manage their, like, say they need a medication? Would that be their primary care physician? It probably would not be their oncologist. Is that right?
Well, actually, it's everyone. And I was, and you know, the purpose of my talk is to try not to. I know some of the things I talked about were a little scary, but my aim is not to scare patients, but rather to empower them. Knowledge is power, and ultimately, you, as the patient, are your best. You're the best advocate for yourself, and you know, whether you're talking about cancer or other you know, diseases. I tell patients that good health is not a passive thing. You know, you really have to work towards it. And it's very important for cancer survivors to try to keep kind of an overall picture of their general health. There are studies that show statistically cancer survivors follow up less frequently with their primary care doctors. And that's a big problem. You know, the cancer, and I've said this in other talks, that the cancer diagnosis is kind of all consuming. And so the focus is on your relationship with your cancer doctor and getting all your studies and getting your therapies and so forth. And diabetics, for example, tend to have worsening of their blood sugar control during that period of time because nobody's really actively focusing on diabetic management. Same is true.
I was going to make that same comparison.
Yeah, I mean, you know that. I mean, right, from dietary
diabetes
things,
management
absolutely.
before oncology, and I came over to oncology. I was like, oncology didn't want to touch it. Kind of the same thing you mentioned about, like, during treatment, your numbers, like your hypertension might go up or down, and it's hard to manage when you're not sure, like with all the other things going on. And so sometimes they just lower their standards for management.
Now, in my experience, oncologists are some of the best general internists that there are, because they do have to try to manage a lot of things as they try to treat the cancer. But again, even for the oncologist, the focus is primarily on the cancer, less so on other medical issues. And the same is true for hypertension. You know, when you're talking about almost half the US adult population has hypertension to begin with, clearly a lot of patients newly diagnosed with cancer are going to bring hypertension along with them already. And somebody has to kind of pay attention to that. It really is important to try to stay with the primary care doctor. And, you know, even primary care doctor may feel, oh, I'm kind of superfluous at this point, I'm not really contributing. But looking after all those other general medicine sorts of things is still important.
Gotcha. Okay.
But having a home blood pressure machine in anyone who has hypertension, cancer or not, I think is a good idea.
Yeah, I think that's an excellent suggestion, because then at least you have some kind of log for your care team to be able to kind of see what's going on.
Yeah, absolutely.
And then they can adjust medication as needed,
or at least bring it to the attention of your provider too. Say, hey, you know, I'm checking my blood pressure at home, it's been really high lately.
Yeah. And I will mention that at Cancer Services, sometimes we have blood pressure, like self-monitoring machines that have been brought to us that we can offer to people if your insurance doesn't cover or you can't afford to buy one, that you can call us and see if we've got one in that we're happy to send home with you.
Mm-hmm.
So tell me if this is right. It seems like lifestyle, of course, is important. I'm a dietitian, so you've actually inspired me next year to do a webinar specifically on blood pressure and, you know, managing that with nutrition choices. But I also feel like you can't rely only on lifestyle, or maybe like if somebody already has a elevated blood pressure, they need to go ahead and prioritize treatment and lifestyle together. Would you say that?
Right. Absolutely.
Okay.
Yeah. Yeah. It's very important. It's hard to manage as a person who manages hypertension day in and day out. If someone is not also trying to limit their sodium intake, if they're you know, overweight and they're not trying to lose a little weight to help, that makes it all that much harder to manage the hypertension. And then, you know, a common complaint, as I alluded to, is, do I really need all these medicines, doctor? You know, I'm worried about side effects. It's hard to remember to take them. I don't know if they're interfering with other things. And one of the things that patients can do to try to limit the amount of pills they take for hypertension is to try to do these non-pharmacologic things, because you do get real blood pressure lowering effect as a result. And it could be the difference between, you know, staying on 1 or 2 blood pressure medicines with good control, or having to add a third one because the blood pressure control is not adequate.
Right. And I also, like, I work with a lot of people who really want to lose weight and they're doing all the things. There's some weight related challenges that are just out of people's control.
Right.
But even if you don't lose weight, being physically active and eating healthy can help with blood pressure management and just overall good health. So,
and again, physical activity, I've given other talks about physical activity and the importance in cancer survivors. You know, there are problems with that too during after cancer treatment, you know, that it makes it hard for people to sometimes be physically active. But the data is that doing something is better than doing nothing. So, you know, we've talked in the past about yoga even. You know, if you're not gonna go out there and, you know, run a 5K or maybe even walk around the block, but maybe you can do a little yoga as kind of a starting point.
Yes, I love that conclusion. But doing anything's better than nothing. I say that about
really
vegetables.
The worst thing to do
any
is
vegetable, any vegetable is better than no vegetable. Any exercise is better than no exercise.
I guess that's true, right?
Sometimes, it's like you in your mind, you're like, well, if I can't do it the right way, I shouldn't do it at all. But that's not true. Like anything will help. So,
absolutely.
Well, thank you so much, Dr. Bodek, for all this amazing information. Again, you can find all of our expert interviews on cancerservicesonline.org/special topic, or on our YouTube channel, or the audio is also on our podcast, The Triad Cancer Connection. Thanks so much for your information, and I hope everybody has a great day. Bye.